that okay? Can I put my microphone on here? Yeah.
You don't.
They need. Yeah. Structure very different.
Oh, sure. Yo, don't worry about it. Yeah, jump in. No.
Yes, so the Korean is.
Oh, no, we have a CHIS assistant director that speaks Korean.
Oh, it's good.
Yeah.
Okay. Oh, okay.
Olivia's hiding over there.
Oh, okay. He hit the jackpot then. All right, cool. Right away.
Folks, we're going to get started just because we have online people who are waiting for us. But a few more people will be trickling into the room, so bear with us. Okay. Hi, everyone. Hello again. My name is Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research. It is my pleasure to welcome you to the last, but certainly not least, of our 2016 Health Policy Seminar Series. And at this seminar today, we will be giving you a holiday gift of new and fascinating health data. All right. Oops. Down arrow? Okay. Mohammed's not. I know. Okay, there we go. There we go. Sorry. All right. But as usual, I want to talk about what's coming up on our agenda. So I just want to give you a heads up about our 2017 Health Policy Seminar Series. We are kicking it off with a bang on January 24th with a very distinguished speaker, Dr. Michelle McAvoy-Doty, Vice President of Survey Research and Evaluation for the Commonwealth Fund. Michelle will be with us to examine the likely effect of various proposals to repeal the Affordable Care Act, specifically on Latinos, who today's research shows benefited a lot from the Affordable Care Act, but depending on who you believe, 18 to 29% of whom voted for President-elect Trump, who has vowed to demolish the Affordable Care Act. So, using data from the Commonwealth Fund's biennial health insurance surveys, Doty will look at gains made in coverage and access for Latinos and discuss options for those at risk of losing coverage, and it should be really interesting. Just so you know, this seminar is co-sponsored by us, the UCLA Center for Health Policy Research, and the UCLA Fielding School of Public Health, as part of 4 special upcoming Grand Rounds seminars specifically on the fate of the Affordable Care Act in the Trump era. Following this upcoming January 24th seminar with Dr. Doty, we will have a February 15th seminar on what repeal and replace might look like in California. And 2 subsequent seminars, dates to be announced, will address what might happen to both Medicare and Medicaid, Medi-Cal. For those of you who attend our seminars in person, I'm talking to everyone in the room and perhaps people online, please note that these Grand Rounds are going to take place in a different venue, room 43105 in the Center for Health Sciences in the UCLA Fielding School of Public Health. That address is on the slide. It's in our website's newsroom, and it will be in our reminder notices that we send out in our free, widely read monthly e-newsletter, Health Policy News. So please stay subscribed. Okay. As for today's seminar, we will be recording it, and it will be placed in our website at the address you see at the top of this slide. If you would like copies of today's presentation slides emailed to you, please send me an email at gdriscoll@ucla.edu. You can find and subscribe to our e-newsletter at this address at the bottom of the slide. And as always, we will have a brief question and answer period at the end of today's seminar that I will moderate. Okay, it is now my pleasure to introduce our speakers, Dr. Ninez Ponce and Todd Hughes. Ninez is the center's associate director and the principal investigator for the California Health Interview Survey. Todd is the new director of the California Health Interview Survey, making his first appearance at a center seminar. Yay, Todd. Ninez, as anyone who tuned in for last month's seminars knows, is a professor at the UCLA Fielding School of Public Health. She's the principal investigator for CHIS, and she's a nationally known expert on ethnic and racial health disparities. She's also someone who has been intimately involved in the CHIS survey since its start, and she is specifically responsible for pioneering CHIS's status as a unique and comprehensive source of data on many undersurveyed racial and ethnic and other groups. We are very proud and excited to boast that we recently stole Todd from the U.S. Census Bureau, where he was the Assistant Division Chief of the American Community Survey, the largest ongoing household survey in the nation. Todd started his career knocking on doors for the census and rose to help oversee this 3.5 million household survey with an annual program budget of up to as much as $250 million. Todd brings to CHIS, to use Ninez's words, cradle-to-grave survey research experience, as well as a strong track record of innovation in both research and methods. We're very excited to have you with us, Todd. Please welcome Dr. Ninez Ponce and Todd Hughes.
Hi, everyone. Thanks so much, Gwen. And it is, we don't want to let you go, Todd, and you'll see Todd come up here after. So I'm just going to start with, for those of you who are new to CHIS, an introduction to CHIS, and for those of you who have used CHIS or have supported us, that it will be a refresher for CHIS. So what's the California Health Interview Survey? It is known as the nation's largest continuous state health survey. We are in the field, I think, every day except for 2 days in the year. We are known as the most comprehensive source of population-based health information on Californians. And population-based information is very important, particularly in looking at access to care and public health. We ask our CHIS respondents, and thank you if any of you watching answered the phone and answered our questions. And as you know, we ask about not just health status, health conditions, mental health, oral health, health behaviors, but also access to and use of health care. So we ask a lot of questions on health insurance, and we also ask questions on the non-health determinants such as employment, housing, food security that shape how Californians live, work, and play, and how we can keep them healthy. So we are in the field all the time each year, and this makes us a great assessment tool to meet not just state needs, but also local needs for the population. We look at, our data is looked at by policy analysts, those who formulate policy, advocates. Our data is looked at in terms of targeting service areas or thinking about new ways to develop public health programs. And our data is also used by researchers, not just in California, actually nationally and internationally. And we love grad students, so please use our data. CHIS is a collect, and there's many of you here who just said yes, they're nodding. So as you will discover, if you haven't already, with not just this webinar, but our fact sheets and our web query systems and our public use files, that it's a tremendous effort that requires that we tap on the many voices in California on how to make CHIS the best product it can be. It's a collaborative project, and it's funded and supported by our partners federally and state health agencies, as well as national foundations and advocacy groups and other researchers. So we provide health and health-related estimates. That's our main goal. But there's three key criteria in how we deliver these estimates. And we must do so that it's meaningful for local communities. So not only do we have statewide estimates, but that the data and the sample is large enough that we can provide local level estimates for counties, cities within health departments, and as I said, statewide. Because California's population is so diverse, we want to make sure that our data represents the diversity of California. And first and foremost is the major racial and ethnic groups. So our data is large enough and meaningful enough that we can provide meaningful estimates for the major racial ethnic groups in California, and if possible, through oversamples with some smaller ethnic groups. Finally, data is only good as it is used, and we really try hard, and you'll see with our different products, and later when Todd demonstrates some of our products, that we share this data to a wide variety of audiences. So how is CHIS done? As I said, our respondents are reached by telephone, and it's through CATI, computer-assisted telephone interview, which ensures that it's a randomly selected sample, so it is a population representative sample of California. We interview not just adults, but we also interview adolescents and children if they're present in the household that we reach. Finally, we are diverse not just racially and ethnically in the state of California, the great state of California, but we're also diverse in terms of the languages that we feel comfortable speaking. And CHIS is indeed conducted in multiple languages, in English, Spanish, Chinese, Cantonese Mandarin dialects, Korean, Vietnamese, and Tagalog. And these languages are chosen and selected by a multicultural technical advisory committee that looks at census data, language data, that looks at linguistic isolation, and that looks like what's the probability that we can encounter a household with the CHIS survey. I'm very happy to say that our staff, particularly Roy Spark, has done a tremendous job with the translations, overseeing that, and we have these translations available on the CHIS website. 2015. I'm so nervous and giddy. We finally got it done. And just so, again, so grateful to all the people that have made this happen, and grateful to the respondents of CHIS. So in 2015, we interviewed over 20,000 households, and we collected information from 21,034 adults, almost 800 adolescents, and over 2,000 children. What I present here is the breakup by race and Latino ethnicity. So we also collect data that's very important for policy, because the importance of data is only important if it can inform how to improve the health of Californians, how to monitor big laws such as the ACA and its implementation. So I'm going to highlight 3 domains of what's new in 2015 data, but there's also many, many more domains. I really invite you to come to www.chis.ucla.edu to explore. ACA implementation. Today we also released a fact sheet. It's like our report card of health insurance in California. This is for the non-elderly population, age 0 to 64. And the key, I think, lines you should look at is this blue line with diamonds, where we see that the uninsured, this is the population of 0 to 64 Californians who do not have coverage or uninsured, and we see that since 2013, pre-full ACA implementation, that we see that it has gone down. In fact, significantly down, that we're close to single digits. It's actually single digits if you don't round up. Single digits at 9.5%. And the key driver here is this red line here with the square. And the key driver of this decline in uninsurance is the surge in Medi-Cal coverage, where we see from 2013, which is 21%, so it's about 1 in 5 Californians, to 1 in 3 Californians in 2015. We also released a new nuanced measure of health insurance. What we were finding in 2015 was an increase in the proportion of the population that I'm going to call them blended, that have both Medi-Cal and employer-sponsored insurance. And so with this growing population, we're releasing this new variable that can track this population. And this then will allow users to evaluate the trends in this dual coverage group and to develop their own health insurance hierarchy. So the good news is that the uninsured rate has gone down. But how has it gone down across different income groups? And this slide here shows that these are the percent of uninsured, and we look at it by household income as measured by federal poverty guidelines. And it's that 0 to 138% is the poorest segment of our California population. The 400% plus FPG is our segment of population that has the most income. And what is heartening here is that comparing 2013 pre-CA to 2015, that we are seeing this decline in the uninsured rate, and we see this decline across all income groups, but the decline appears to be greater in the poorest segment of California's population. Looking at the uninsured rate by race ethnicity, we also see that the ACA appears to have benefited all Californians, regardless of race and ethnicity. But again, what we see that the communities of color, so up here is non-Latino white, but we see that Latinos, Asian Americans, and other Pacific Islanders, African Americans, that the decline of uninsured rates are seem to be much higher than non-Latino whites. But again, to emphasize, all groups have benefited. So the Affordable Care Act is called the Affordable Care Act. Is this new world, or threatened new world to be repealed, does it make coverage affordable? And we have a question in CHIS. If they're currently uninsured, what the main reason is. And one of the reasons is because they can't afford it or it's too expensive. And since 2013, so comparing 2013 to 2015, we're seeing that, again, across all the income groups, there's been a decline in the proportion of Californians that say the main reason why they can't get coverage is because it's too expensive. And again, we see that the decline is biggest among the poorest segment of the population. So we ask,
We're just getting questions related to this.
already, sure, okay.
One is that people want to know, do we call cell phones as well as landlines? That's an easy one. And can you remind people how CHIS defines uninsured? Does it mean lacking health coverage all year or just the time of the year?
Thank you for those questions. I think Gwen answered that. The question was, do we also call your cell phones? And yes, we do. In fact, this year we have gone, in 2015, we have gone from a 20% cell phone, 80% landline sample design to a 50% cell phones, 50% landline. We didn't exactly hit that target, but that's about it. And this is actually good because many people who have cell phones or cell phones only tend to be the group that we missed in just looking at landlines. So they tend to be younger, they tend to be seasonal workers, they tend to be Latinos, they tend to be lower income, they tend to be younger. So I think that this is a plus in terms of our reducing what we call coverage bias in sampling. The question about the uninsured by Scott Graves is a good question. So this is based on the current uninsurance rate. So it's not a question in I think CPS changed it. So I'm looking at Todd, our census expert. So CPS changed it. So it's not the past year, and it's not uninsured the entire year. So this is the question. You get called and you get asked actually a series of questions about different coverage sources, and through those questions, or like we funnel through all these questions, and then we ascertain whether you're uninsured currently at the time of interview. Any more questions, Gwen? Okay, thanks for that question. So for Californians who may have delayed or forwent care, necessary medical care, again we ask, well, what was the main reason? And cost is a reason that can be identified. And among those who delayed necessary medical care, again we're seeing that the reason that if cost is the reason, that's also declined from 2013 to 2015. And we see that the decline here and the star here shows that it's a significant decline, statistically significant decline from 13 to 15, that we see that the biggest declines are for those Californians whose incomes are 0 to 138% poverty level. Another part of the ACA is the incentives and promotion of getting a routine checkup. So now you don't have to pay a copay to get an annual exam. And so that monetary incentive then could possibly help people in getting a routine checkup. So let's see how the ACA did. 13 to 15 in 2013, those who received routine checkup in the past year was about 69%. And in 2015, it grew to 73.1%. And the difference between 15 and 13 is statistically significant. Oh, I used the wrong thing here. So now I'm going to pivot because I think what's worrisome with not just the repeal of the ACA is the sense of stigma, fear, trauma of how you're being treated. And so CHIS in 2015 started asking a question on discrimination, and I actually thank Office of Health Equity for supporting us in this question. So this question asks, over your lifetime, how often were you treated unfairly when receiving medical care? And the proportions I show here are those that responded sometimes or often. And we look at it by racial ethnic group, and we see that, let's first look at non-Hispanic white, it's 10.4%. That Hispanics at 14.2%, so 4 percentage points higher than non-Hispanic whites and significant, reported that they were treated unfairly when receiving medical care. For non-Hispanic African American, 15.1%, also higher, although not statistically significant. But I have to remind you that our African American sample, which reflects the population, is a much smaller sample than Hispanics. Non-Hispanic Asians significantly report actually lower percent who were treated unfairly when receiving medical care as compared to non-Hispanic whites. And then we have non-Hispanic other race or multiple race. It's a bit hard to disentangle because it's an aggregate category, but we have this here as a reference, and we see 15.2%, which is again higher than non-Hispanic white, although not statistically significant. So discrimination comes in many ways. The first set of questions I showed was on exposure. Where are you treated unfairly? It's unfair treatment. This question is the feeling that you would have received better care if you belonged to a different race or ethnic group. So it's perceived discrimination, the sense that that there might be differential treatment just based on race ethnicity. And in this case, this question actually made a comeback, and we put it back as an anchor to a question we asked back in 2005. And in this case, that we see that Hispanics compared to non-Hispanic whites had higher proportions who felt they would have received better care if they belonged to a different race ethnicity. And in this measure, or in this construct of discrimination, we see significantly higher results, higher proportions of non-Hispanic African American saying that they would have received better care if they were different from race ethnicity. Another thing that's really exciting for us with CHIS 2015 is adult gender identity and teen gender expression. With the Williams Institute, the UCLA School of Law, we've been working with them on including in CHIS measures of gender identity in adults and gender expression. I know that many of you who are here joining or have certainly emailed me and Todd and Matt Jans over the last few weeks, very curious if we are going to release the transgender estimates, but given small sample size, we're going to wait a second year for data collection in 2016, and then we'll release the data for these topics in our online tools, such as AskCHIS. But you can access this through the research available through the Data Access Center. But let me tell you a bit more about how we implemented this question. We actually did some preliminary work before 2015 to see if one question, like including transgender identity with just the general sex question, are you male, female, transgender, versus a two-stage question where we ask a question about what sex were you assigned at birth on your original birth certificate, for example. So we did that experiment, and and the results showed that a two-question was better. So we did implement two questions in 2015 CHIS, but then we did an extra experiment we alternated between this Q1, which is what sex were you assigned at birth on your original birth certificate. We asked this of a random 50% of our cases. And in Q2, we asked, do you currently describe yourself as male, female, or transgender? So for more information on this, I'm going to, where's Matt Jans? I'm going to call out Matt Jans, mjans, M-J-A-N-S, at ucla.edu, because I think he has many articles that he's writing right now, and hopefully this will come out in 2017 with our colleagues at Williams Institute, so we thank them. So what's also, I think, really innovative now in the CHIS survey is we also ask about teen gender expression. And so gender expression is different from gender identity. Gender expression well, here's the question. A person's appearance, style, dress, or the way they walk or talk may affect how people describe them. How do you think other people at school would describe you? Very feminine, mostly feminine, equally feminine, and masculine. Mostly masculine or very masculine. So we will, it's not, again, these won't be available, adult gender identity won't be available, but here's a peek at these estimates from 2015. This panel here on the left is adult gender identity, and the panel on the right is teen gender expression. They're not the same scale, so I point that for gender identity, it's about 0.25% of adults 18 to 70 who identify as transgender. However, if you look at teen gender expression, and again, different construct, but getting at the sense of gender conforming or non-conforming rates. So for teen gender expression, we have close to 5% of youth aged 12 to 17 who report very or mostly non-traditional gender expression. So again, for more information on the gender expression, gender identity, Matt Jans, and then for more information on CHIS as a whole, Todd Hughes, who I'm going to introduce now and invite up to the podium.
Thank you. Good afternoon. I'm so excited to be here today to talk to you about our release of the 2015 California Health Interview Survey data. It certainly represents a culmination of a lot of work by a lot of great people, many of whom are in this room, so kudos to the team. And as you saw, some of the data that we released is especially timely and relevant in today's climate. So we've given you a few highlights of some of the most relevant and timely topics, but we also want to point out that there is a world of data that is waiting for you now. It was all released online this morning, and you have access to it immediately. We encourage you to dive in and learn more about what the data have to offer. But we're going to go through some overview of a little bit about what's new in the CHIS this year. So first of all, we have covered some of these topics in the earlier slides, but there were some new questions added to the adult interview that are listed here on this slide. Some of the items that we didn't discuss were reasons for not seeking mental health care, use of telemedical care, birth control method currently used among women aged 18 to 44, and some reinstated content about mammography exams, current birth control use, and pregnancy status. In addition to those new questions, there were some revisions made to the child and teen interviews for 2015. That included for the teens asking about psychological distress in the past year, as well as the gender expression construct that we just described. On the child questionnaire, you can also find new information about delays receiving dental care, ER and urgent care visits for dental problems, and parental awareness of the First 5 California program that's entitled Talk, Read, and Sing. So we partnered with First 5 California in measuring awareness of that campaign. As related to the earlier question that came up and the explanation that Ninez provided, we did have a significant change in our sample design for 2015 related to the frames that we used, whether the proportions specifically that we used between landline and cell phone interviewing. And this was a move to increase the cell phone frame so that we could better represent the characteristics that are unique to those households that have only cell phone access. Certainly the landscape has changed significantly over the past several years, and we want to be sure that the CHIS data reflect that most accurately. We do want to describe for you as well a modified approach to data collection that took place in 2015. Specifically, as part of our preparation for the 2015-2016 data collection cycle, we went through a competitive bidding process for a data collection vendor, the company that actually makes the phone calls to collect the interviews. And in 2015, that data vendors changed to RTI International. And they proposed and we implemented a two-phase sample design. What that means is, after the first phase of data collection for each quarter sample, we changed the approach that we used, such as modifying the follow-up procedures, focusing on a subset of those interviews, modifying the incentives or other approaches that we took to try and obtain data. And why would we do that? Well, we did that for a couple of reasons. Number one, to improve efficiency from a cost perspective, but also to primarily focus on reducing the risk of non-response bias. The characteristics of those who respond to surveys easily are different than the characteristics of those who are more difficult to obtain an interview. And so this two-phase sample design allowed us to better reflect the characteristics of those households and ensure that we're reducing the bias that might be present in that kind of design. Additionally, the CHIS has had a history of including oversamples, increasing the sample of certain population groups or certain geographic areas. And in 2015, we continued to do that for Korean and Vietnamese Americans, as well as, in partnership with the Cairo Foundation, a new Japanese oversample that began in 2014 and continued into 2015. An additional partnership with Marin County Health and Human Services led to us increasing the sample in 2015 of addresses of phone numbers and addresses in Marin County. We also made some interesting changes to our race and ethnicity coding in the 2015 CHIS. Specifically, historically, when we had a Hispanic or Latino respondent who reported American Indian or Alaska Native, but did not provide a specific tribal affiliation, they were coded as not having AIAN racial identity in the data. We changed that for 2015 so that the opposite is now true, even if they did not provide for us a specific tribal affiliation. There were some refinements as well in the 2015 California Health Interview Survey and the ways that we measure Medi-Cal eligibility. So Medi-Cal eligibility has different criteria that may be applied, one of which is eligibility due to medical need only. And that has always been subject to asset testing, and the CHIS has tried to reflect that. However, in 2015, we expanded the set of questions that we ask related to assets reported to better understand this asset eligibility component of medical need. And that specifically included the additional questions related to ownership of secondary vehicles and property, which was included in our calculations for 2015. Next, I'd like to change gears a little bit and talk to you about how the data are available and why it's our goal to make the data available to as many users as possible. We have some key goals that are part of our dissemination strategy and objectives. First, we must always protect respondent confidentiality. That's a key thought and process that guides all of our decisions that we make regarding data dissemination. Second, our key objective is also to democratize access to the data. We want the data to be available widely without broad limitations. We want to make sure that anyone who has a need for it and could use it in influencing health in the state of California can have access to it. And third, we recognize that that broad and diverse set of users has a differing set of skills and technical ability. And so we want to be able to provide different tools that reflect those different abilities. So I'm going to describe a little bit what we have available. So first, this slide presents some varying types of access to the data. And it starts with those who are most technically savvy and have the most specific and complex needs for data analysis and for research. And that involves using our Data Access Center. It's a secure network. It allows us to partner with outside researchers where we can have access to the core source data sets and really produce a set of analytic results that provide the most detailed information while protecting confidentiality. One step away from that would be what we use in our public use file. This file was released this morning. It's available for your download as we speak. We encourage you to dive into it as you have the abilities and the needs to use it. It's available in SAS, SPSS, and Stata formats. The public use file provides record-level information for the households that we interviewed. So it allows you to run your own tabulations and do your own programming to cross characteristics by other characteristics and really dive in. We shared with you a few highlights of some of these most relevant topics today. If you want to look at those same topics crossed by any number of other topics, you can use the public use file to be able to really dive into the data. And then these three orange topics here, these orange tools, are ways that we release data through online systems or are targeted for maybe less savvy data users. And the first is the Ask CHIS system, which provides an online help data query tool for higher levels of geography. Ask CHIS Neighborhood Edition, which goes much more granular in the level of detail and the level of geography that's available. And that's followed by health profiles, which are perhaps the most simplified version of the data that we release and accessible to the masses. These are just online PDFs that describe key health characteristics. I want to point out to you as well that the UCLA Center for Health Policy Research has a program called Health Data. And that program allows us to really work with interested parties in providing training that would increase the capacity of those organizations for data, for advocacy, and assistance in using the data. All right, I want to compare in this slide for you two different online tools that you can go to today to access CHIS data. The Ask CHIS system provides data for both state and counties, as well as some sub-county geographies for Los Angeles and for San Diego. Whereas the Ask CHIS Neighborhood Edition is what tool you would use to really dig into small levels of geography, such as assembly areas, Senate, congressional areas, cities and zip codes, and I'm going to give you a quick demonstration of how we can, those tools are available for you to use. So this first portion of the demonstration is related to the Ask CHIS system. It provides the data, as I said, at higher levels of geography. The first step in using it is to select here a geographic area that you're most interested in. You can leave it at the default for the entire state, or you can dig into individual counties or multi-county regions, as well as I mentioned, sub-county areas for Los Angeles and San Diego counties. Next then, you're allowed to select a set of topics. So they're grouped here by topic category. You can drill down into more specific topics, and then pick the individual data set, individual construct that you'd like to measure. The next step then allows you to compare that with other topics of interest. So in this case, although the topic that we're interested here is whether you were ever diagnosed with diabetes, we're now crossing that by height and weight, and specifically by the body mass index. And then finally, you can limit the data by certain population characteristics, basic demographics, etc. So by age, by gender, by race category, or by federal poverty level, you can choose to limit the set of cases that would be included in the estimates that are produced. And then finally, I'll show you, in tabular format, you receive an output that shows the characteristics that you've been interested in for the geography that you selected. So it's a very easy to navigate, simple tool, and I'll mention to you, we've released over 200 new indicators here for 2015 that's currently available right now, and I encourage you to dive in. There's another very powerful tool that allows you to go below that level of geography called our Ask CHIS Neighborhood Edition. The Ask CHIS Neighborhood Edition allows you to select a set of topics from the list on the left side. It then allows you to cross that by certain locations. And what's very powerful is this location selection can go not only state and county, but down to cities, down to zip codes, down to congressional districts. and then produces a visualization of your data. I do want to make it clear that the 2015 CHIS data is not yet available in Ask CHIS Neighborhood Edition, but it is a very powerful tool that you can use. So let me show you, after you've made those selections, and in this instance we're looking at multiple characteristics, whether the population was ever diagnosed with diabetes, obese, their patterns for exercise and drinking sugary drinks. And that was crossed at the state level, at the Los Angeles County, drilling down into a certain congressional district, down to the town of Downey, and a certain zip code of 90241. And you'll see that it produces a map interface. Now, the map interface is very exciting. And I have to admit that the first time I went into this interface, I was swallowed up in the system and spent maybe more time than I should have examining these maps. But they're very powerful and very interactive. So here was the zip code we had selected. It provides some characteristics about that zip code. It allows you quickly to select any other zip code and look at it. It also provides an interactive histogram at the bottom of the screen that you can set filters within ranges, so you can limit the display to those that have the characteristics of interest that you're looking for. One other item that I want to share with you is, finally, related to the Ask CHIS Neighborhood Edition, you can also export these beautiful maps and data visualizations into formats that would allow you to port that into other presentations or reports or grant applications, other strategies to help influence health in the state of California. And we do have a new application called an API that allows you to take all that CHIS Neighborhood Edition, all the very detailed data, and download it into your systems to allow you to do the manipulations that you need to do for your own proprietary systems. It's a very powerful application. If you're interested in it, an email to chis@ucla.edu will allow us to put that in contact with, put you in contact with the right people. So I do want to, at this point, encourage you to see all that the CHIS has to offer for our 2015 data release on the website listed at the top of the screen, www.chis.ucla.edu. And I also want to extend a special thank you to the many talented, dedicated employees who work here at the UCLA Center for Health Policy Research on the CHIS. I've listed their names here. Many of them are in the room. If we could turn the camera and put them all on the spot, I would, but we'll spare you that today. We'll spare them that today. However, there's also a very talented set of folks who work in communications and IT and administrative support who have helped this program, and we want to acknowledge their contributions on this exciting day of our release. Thank you.
We have questions now. The way we do it is I take one question from the room, I take one question from our online folks, and so on and so forth until we're out of time. So I am going to start with online because we have a question on what is the effect of the change in cell phone sample on comparing race ethnicity in 2015 to prior years. And if you could repeat the question back so our online folks can hear.
Great. So the question is, what was the impact on the change of our sample design on our estimates of race and ethnicity? So producing statistical estimates is a multi-step, complicated process that includes weighting the data to some fixed estimates that, in our case, come from the California Department of Finance. So we use those state-level estimates of race and ethnicity to weight and adjust our survey data so that it's most reflective of that group. So the characteristics of those who respond by cell phone are likely different than the characteristics of those who respond by landline, but the way that the weighting of the data adjusts for that does not create a different estimate of race and Hispanic origin for the state.
Any questions from the room?
Oh, I have one question. I mean, the first graph that the doctor showed us earlier, the graphic shows that the medical insured people percentage went up, and then the uninsured percentage went down. Is it because of the Covered California or Obamacare with it?
Well, Obamacare also includes expansion of the Medi-Cal population, so that's part of it, and it also includes Covered California. So Covered California is in the individually purchased group, but mind you that individually purchased group is a smaller proportion of coverage, and this includes both within Covered California and outside of Covered California. So this is this is together. But we do see that it has, at least compared to 2013, 6.1% compared to 7%.
So that means people's economic status has been down in California, especially because of the medical insurance going up, which is for the lower income peoples, right?
No, I think you can argue that the eligibility for Medi-Cal has expanded.
Thank you.
So online question, about neighborhood edition, can you search by census tract? If you could repeat the question.
Sure. So in Ask CHIS Neighborhood Edition, are you able to search by census tract? We would love to do that. We're not able to do that yet. Unfortunately, the lowest level of geography that's currently available in Ask CHIS Neighborhood Edition is the zip code level.
Any questions from the room?
I had a question actually about the gender identity questions that are new.
Okay, we're going to go back. We're going to zoom back there, right?
It's not that complicated. I just was wondering if those are in addition to the sex or gender question that has been asked every year since CHIS began. Are you male or female? Is that in addition to that question?
Yes, it is in addition.
Repeat the question.
Oh, the question was whether the questions on gender identity that is displayed here in the slide, if these are in addition to our core demographic questions where we ask about gender, are you male or female? And yes, these are in addition.
So we have an online question. Have you included the 200 plus indicators on your website? On top of the file, surely, but I guess the question is more to ask CHIS.
Right. So have we included the 200 indicators in our website? So if you log into the Ask CHIS system, the very first screens that you'll be the very first screens that you'll receive are those that allow you to drill down to geography, and then after selecting a geography, there are individual topics listed. They're grouped by topical area. So those 200 indicators, once you drill down into all of them by topic, by condition, then you can get the specific indicators and constructs that are available. So they're grouped very logically, and it's a very intuitive and user-friendly method to be able to find the data that you're looking for.
Yeah, I believe the cell phone sample will be younger. So compared with this year sample, cell phone sample versus landline sample, the pattern persists.
So the question was, given our change in landline versus cell phone sample, we would expect that cell phone users would be younger and have other characteristics that are different. And did we find that in the data? Yes, we found that the cell phone respondents were generally younger, were often of different race and ethnic groups than the landline-only households. And so being able to increase the data that we collected through that frame allowed us to make sure that we were reflecting those populations appropriately in the total weighted estimates that we produced. Yes, and a follow-up.
So the cell phone sample, okay, CHIS is the sample members
That's a good question.
population, right? And so when you have a cell phone sample, do you purposely excluding those in the dorm and living in the dorm like a college students, or you don't?
To the extent that our frame, the question was, given that the design of the California Health Interview Survey excludes the institutionalized population, does the cell phone frame that we use exclude those who are residing in dorms or other situations? So it's difficult to identify that perfectly on our frame, to identify whether a cell phone number is associated with someone who's living in a dorm or some other sort of residential status. But our early questions in the interview refine their eligibility for the survey, and so we ensure that they meet our criteria for inclusion before we continue with the interview. Go ahead.
So online question, how are programs such as Healthy San Francisco or My Health LA classified as insured, publicly covered, or uninsured?
So is Tara here?
We can also get back to people on that.
We can get back to people on that, but one of our other researchers, Nadi Parat, says it would be in other public.
So you can repeat the question so our online folks can hear. How are programs such as
This is from Alex Medina. How are programs such as Healthy San Francisco or My Health LA classified as insured? Yes, they are insured. Publicly covered or uninsured? They would be classified as insured under the other public category.
Have you noticed a difference in the response rate for the cell phone sample, the landline and the cell phone sample?
So the question here in the room is, have we noticed a difference between the response rates for the landline versus the cell phone sample? And yes, we have noticed a difference. In general, the initial screener phase of trying to identify whether the household would participate in the interview, that tends to be higher among the landline sample than among the cell phone sample. But as you look at some of the other rates, it varies. The rate of collecting an adult completed interview for that household was higher among cell phones versus landlines. So there are some trade-offs, but overall it seems like they're both very effective and an important part of our data collection.
And Neighborhood Edition has 2015 data coming when?
So the question from our online participant was, when will the 2015 data be available in CHIS Neighborhood Edition? So in general, we would wait for a 2-year cycle to complete. The 2015-2016 data collection cycle would need to be complete. So that would be ideally towards the end of 2017. That would be included. However, that is pending the receipt of funding to be able to support that effort.
Thanks, Todd. I also just want to call out Bogdan Rao, who's in the audience, who was a chief architect of CHIS Neighborhood Edition.
So we have time for a few more questions. Any in the room before I go to online?
What's the difference between what's available in the API and the more detailed information?
So the question is, what's available in the API and how does the level of detail compare to the other tools, the other products that are available? So the API gives you access to all of the source data that is included within the CHIS Neighborhood Edition. So everything that you can dive into in CHIS Neighborhood Edition can be extracted and pulled through the API.
Instead of going by yourself, I think it's just, is it five local areas by local areas. So it also allows for other institutions that have websites or dashboards to seamlessly incorporate the CHIS NE with their dashboards.
With the recent changes in methods over the past few cycles, are you making recommendations regarding trending CHIS data?
That's an excellent question. So are we making any recommendations regarding trending of the data given some of the changes in methodology? No, at this point we are not recommending that you consider any of these as a break-in series. However, we do plan to release some more information about some specific adjustments that we had to make in the 2015 data to inform data users on some of the impacts of those decisions, and the user can decide how that should influence ways that they would use the data. I think that the data the weighting strategies that we use to conduct, to produce the actual estimates is designed to smooth and account for a lot of those differences over time, changes in response rates, changes in our frame and other methods.
We have time for maybe 2 more questions. So any questions in the room?
Maybe a complex question, feel free not to.
We were just given license to not answer Nadi Farat's complex question.
Usually, for some of the analysis, combining the 2 years of CHIS are advantageous because it gives you a bit larger sample size, more power to make comparisons. And given the 2000, so the logical thing would be combining 14 and 15 data for estimates of insurance coverage, for example. But 2014 was a transition year with the increase in coverage. I just was wondering whether you want to make any comments about the combining the 14 and 15 for insurance coverage estimates.
Do Okay, so the question was about if we should provide any guidance or caveats in combining 2014 data with 2015 data, given that these 2 years are post-ACA. And I think the caveats are more content-oriented rather than survey methodology oriented. It's that because not just CHIS, but in other data sets, in other enrollment data sets, the 2014 was a transition year. So I think it's at the discretion of the researcher whether they want to combine it. They certainly can combine it, but it really depends on what your research question is, and then the caveats are knowing that 2014 may not have been a representative banner year for the ACA, because whereas 2015 has much more stable estimates on the ACA. I do want to do a plug again, because I didn't really get a chance to explain why I chose the uninsured estimates, the gender identity and the discrimination questions to highlight as what's new, because as Todd said, there are many, many more things that's new, and we invite you to discover them in the CHIS data. I think those three are emblematic of CHIS's commitment to really taking the pulse of social penalties in a population. And sometimes some of these questions, some survey researchers or others in the industry say, oh, you can never ask a discrimination question on the telephone across in Korean, Vietnamese, Tagalog, Cantonese, Mandarin, across different racial ethnic groups, across different ages. So I think it's something that we try to strive at CHIS, is to delve into how do we do it, how can we do this. The gender identity, certainly another example where, how can you ask transgender question? Might it turn off the rest of the population to ask this? And so, again, we did it with rigor. We did it with checking in with our constituencies. We did it with checking in with experts, not just in California, but also nationally. And actually now, I believe we're the first really large population-based survey that has the gender identity question, definitely gender expression. The uninsured, we've been in the business of measuring uninsured rates for over a decade. I think it used to be called, I recall Rick Brown we used to call it California Health Insurance Survey rather than a California Health Interview Survey. So we've been in that business for a long time. But now we're seeing trends in the market. Again, trends in its transition of people who are, may have been confused in reporting what they had. So that's why we're releasing a more granular, nuanced variable. You can still use all the other variables on insurance, but now it offers the flexibility for researchers to really understand what's going on with this market.
So final question, do the new PUF files allow for county group analyses?
Unfortunately, so it's a good question. Do the new public use files allow for county or sub-county or county grouping analyses? Unfortunately, as I mentioned, our highest priority when it comes to our data dissemination aim is to protect respondent confidentiality. And in order to make that possible, we have made a decision that we will not release any sub-county or any sub-state geographic information on the public use files. However, it is still a very rich data source. And if you have need for sub-state analysis, we encourage you to reach out to us and work through our Data Access Center to look at ways we can provide that information to you.
I think the question is more, does it allow for county or county group analysis?
No. So
no.
In the PUF, the highest, there's no geographic
No.
identifier other than this is a state of California resident.
Not now, and it never has been.
Right.
Gwen, I think you might be missing Shirley Harlan's question on elder persons.
I tried to
did you?
answer
Oh, you did already? Okay, great.
Go ahead. I told her that.
CHIS is asked questions, all ages.
All right, well, thank you very much, everyone. And thank you, Ninez and Todd.
Thank you.
Yes.